associate professor in the Division of Pulmonary Critical Care and Sleep Medicine at UW. He's a clinician at Harborview, but he's also a TB investigator. He's funded for studies of TB infectiousness, transmission, and epidemiology in Kenya. He was my mentor in fellowship, very well respected in the pulmonary community. Also has, as I understand it, quite an extensive record collection, which he probably won't tell us about today. But it's really a pleasure to have you back, Dave. Thank you for coming back. Please take it away.
Great, thank you. It's a pleasure to be back. You invite me back roughly once every 2 years, so thank you. Thank you for that honor and privilege, and it's great to see some familiar faces out there. Without, I think, any further delays, I'll just start the presentation. Okay, so today I'm going to talk about subclinical TB. So I don't have any conflicts of interest to disclose. Here are the objectives. Upon completion of this session, you hopefully will be able to understand the various definitions of subclinical TB to enhance patient diagnosis and acquire knowledge on the global epidemiology of subclinical TB to apply risk to communities in the US. So first off, terminology, we call it subclinical TB. Sorry. I guess I think, let's see if I can try that again. Here we go. You're still seeing the right view, correct?
Correct.
All right. So subclinical TB, I have this. Does anyone know what this symbol stands for here? Just unmute and let me know, please.
That's
Prince's formerly known as Prince.
That is right, because subclinical TB is the disease formerly known as subclinical TB. Since a couple of months ago, it's been known as asymptomatic TB by the WHO. And this is based on just patient advocates and TB survivors at a WHO meeting in October just pointed out that this is a clearer and more direct term to use to describe the condition. So what is asymptomatic or subclinical TB? And I may go back and forth between the two terms. So it's a person with TB, and it's typically defined as pulmonary TB because it's usually based upon prevalence surveys and whatnot. So a person with pulmonary TB who does not report symptoms suggestive of TB during screening. So maybe you have pulmonary TB and you report that your foot hurts. That's a symptom. That would be subclinical TB. The WHO defines it as bacteriologically confirmed or unconfirmed. Again, they've moved away from the less clear terms of clinical diagnosis. So either you can have some evidence based on a PCR test or smear culture of TB, or you don't, and you treat the person and they respond. But my talk is not really going to offer you a lot in terms of how to manage patients in the US with this condition, because this is TB disease. You don't manage them any different from symptomatic TB. Really, the attention that it's gaining is based upon a realization that it may be important as a driver of TB transmission and persistent high burdens. And that if we just rely upon old systems for identifying people with TB, that the endemic is going to continue. So it's asymptomatic TB. What is a symptom? A symptom is a subjective evidence of a disease or medical condition that can only be reported by the person experiencing it. In other words, by the patient. So a patient may tell you that they have a cough, or that they feel like they've had a high temperature or a fever, or that they've been losing weight, or that they've had night sweats. Again, depending on the definitions you use for asymptomatic TB, a person with chest pain and TB might be considered subclinical. Now, a sign is an objective finding of a disease or medical condition that can be observed or detected during examination or lab testing. You may be in a patient room with the patient, and the patient says, I do not have cough. And then 3 seconds later, you hear them cough. So the symptom would be they don't have a cough. The sign would be that you observe them cough. This is just from the WHO website showing definitions of asymptomatic TB and the current or the old definitions. TB disease, so you could have TB disease with symptoms or asymptomatic TB, and it can be either bacteriologically confirmed or unconfirmed. And that's replacing this term of clinically diagnosed TB. A little bit more terminology, because a lot of what I'll discuss applies to sort of prevalence surveys and identification of people with TB in endemic settings. Passive case finding is what happens when the patient goes to the emergency department or goes to the primary care physician saying, I have symptoms, I have a cough, I'd like you to figure out what's going on with me, or give me antibiotics or treat me. So it's relying upon the person to present for health care, detecting TB at health facilities among persons that seek medical care on their own. So it's usually based on symptoms. Well, why would a person without symptoms who feels perfectly well come to see a provider outside of perhaps the annual checkup? And often, because you're waiting for symptoms to get bad enough for someone to present, often it leads to a later diagnosis of TB with more advanced disease. And one of the problems of this, particularly in endemic settings, is it can lead to more opportunities for transmission because there's a delay in diagnosis. Active case finding strategies are in some way the healthcare system, public health, is going out and screening for TB. So that might be, well, it might be in an HIV clinic where someone comes in for their antiretroviral management, and you screen for TB by asking them about cough, weight loss, night sweats, or fever. It could be that you ask someone who accompanies a sick person to a hospital about these symptoms. Or it could be that you're going out into the community and screening, door to door based on symptoms or chest x-rays, or it could be targeted at high-risk groups. Advantages of this are that you can get earlier diagnosis of TB, and that it's presumably going to be less advanced TB. Now, in a low-burden setting, this would not be cost-effective. Up until the 60s in the United States, this was often an approach that was taken. In a high-burden setting, it typically is cost-effective. Whether or not a country or a healthcare system has the resources to do it is a different matter. So all of a sudden, in the last couple of years, there's been a ton of increased awareness and attention to subclinical or asymptomatic TB. And in part, I'll go through the sort of data behind these different things, but in part, it's been newly recognized as to how common it is. If you go out and do these community-based prevalence surveys where they go door to door and they screen typically people 15 years of age and older with symptoms or cough or chest x-ray and collect sputum from those people, you will find that roughly 50% of prevalent TB in the community is amongst people who are asymptomatic. There has been a lack of progress in meeting global TB goals. Since the 80s, when there were ambitious goals to eliminate TB by 2005, we constantly failed to meet them. And in part, this was because the original goals relied on people identifying people with smear-positive disease who presented for healthcare through passive case finding. And that has not worked. And there's a growing realization that, in part, one of the reasons it may be failing is because of asymptomatic TB and a need to go out and find those people in the community. And there's also a growing consensus that subclinical TB may be a major driver of TB transmission. There's been some recent work that suggests that perhaps cough is not essential to transmission of TB, and this is really gaining a lot of traction. Now, the public health importance of subclinical or asymptomatic TB depends on how common it is, its natural history, like untreated, what happens to people with subclinical TB, the infectiousness of someone who has subclinical TB, and whether or not we can accurately and cost-effectively detect this variant of TB. So, symptoms, this is from Emily Kendall's talk at the Union Conference last month, but symptoms aren't a bright line, meaning that someone with symptoms could have, so all TB, someone with symptoms can feel sick enough where they're wasting away where they come for healthcare. Someone can have symptoms and delay in seeking healthcare and not seek it out. Now, typically in the past, the WHO relied on this definition of persistent cough, a cough lasting 2 or more weeks as a screen for TB. And we know that that has a really poor sensitivity. Or you could use any of this typical 4-symptom screen, the WHO 4-symptom screen, or W4SS, which is the cough of any duration, fever, night sweats, or weight loss. There may be patients who you carefully, but there's patients who you carefully probe and ask them again and again, and maybe one person asks them, and the second person asks them, and to the second person, they elicit symptoms. There may be people who you can't elicit symptoms from. There may be people who, once you've told them they have TB, they say, aha, I actually have had a cough. Or now that you mention it, maybe I've lost about 10 pounds. And then there's people who truly feel well. So just to bring home, the symptoms are a very objective personal experience. So why would someone have no symptoms? In part, I think it's this spectrum of TB where it's a balance between the host immune system and the bacillary burden, and where someone lands on that, whether they self-heal, whether they progress, whether they stay in this equilibrium. So someone might, when you ask them who has TB, might say, deny having symptoms because of the way the question was posed. Do you have a cough for greater than 2 weeks? No, I've had one for like the last few days. In many places, there is a stigma to having TB, in part because it is thought that people will suspect that you have HIV. They should suspect you have diabetes, but that they'll suspect you have HIV. And so they may not want to sort of admit to that. Or maybe someone has a chronic cough. You don't mean, do I have a different cough? Because I've had this cough for 2 years, which may be TB related or non-TB related. Someone may be unaware of a cough, and it may actually be present, just as someone may be unaware that they snore, and they deny it until you show them a recording of their snoring. Or someone may be truly without symptoms or signs. And then there's questions around the natural history, which I'll touch upon. So the classic model of TB was that an uninfected person is exposed, and about 30 to 40% of close contacts may have evidence of infection based on a tuberculin skin test or an interferon gamma release assay. And then over the lifetime, about 10% of those people will progress to TB, with the other 90% dying from something else and never experiencing an obvious ill effect from TB. We now believe, and when I say we now believe, we sort of knew, going back to the pre-chemotherapeutic era, people did self-heal from TB. Sometimes you had to send them to the Alps or to like a solarium, and sometimes they just did it on their own. But the model is actually much more complex. Someone may become infected and clear on their own and still have a positive skin test or IGRA. Someone may move on to minimal disease. And by this, I mean sort of an incipient TB, that there's no microbiological evidence, but things are warming up. They may go to a subclinical state, or they may skip minimal disease. They could even skip the subclinical disease and go on to symptomatic TB. And that it's not unidirectional. You can move between states. So someone who had subclinical TB could go and clear on their own or go bounce back and forth. And a minority of people who are not treated will go on to death. So, I mentioned that it's a common thing, subclinical TB, in high burden settings. So most data from high burden settings are based on prevalence surveys. These WHO protocols where you map out, maybe 100 neighborhoods from throughout the country, because you want to know the point prevalence of TB. And you go door to door, and anyone who's 15 years of age or older, you ask them if they have a cough, and you do a chest x-ray on them. And if either are abnormal, you collect sputum. So this systematic review looked at 28 studies, prevalent survey studies from Africa and Asia, and found that the median percentage of subclinical cases was 50%. Now, it varies depending on how you define subclinical TB in terms of the symptoms that you look for. Many of these studies only collected sputum if someone had a cough, or if they had a persistent cough even. The studies that did involve chest x-rays on everyone found that about 90% of persons with TB had an abnormal chest x-ray. So chest x-ray is not perfect. And you have to recall, if you're using as a trigger either a symptom or an abnormal chest x-ray, there are people out there who have a normal chest x-ray and no symptoms, and yet if you collect sputum, you will grow TB from them. So when I say, what I'm offering here, though, is not meant to scare people into deviating from current protocols used in the United States. I'm just trying to demonstrate that TB is far more complex than we realize or have realized. Again, the definition of subclinical TB strongly depends on the definition that's used. If you say, do you have a cough for greater than 2 weeks, 83% of people with TB will not meet that definition. If you say any cough at all, 63% will not meet it. And if you go down to those 4 symptoms, those WHO 4 symptoms, about 28% of people will be truly, using that strict definition, asymptomatic. Now, studies have demonstrated that this TB without cough is more frequent among women. And again, I will say that it's likely an underestimate when you use either a cough or x-ray to trigger sputum collection. In our study in Nairobi, we accidentally collected sputum despite no cough in a normal chest x-ray from about 450 people. We did a prevalence survey in Nairobi of 6,500 people. And we accidentally collected sputum from this number of people, and 5 of them had culture evidence of TB. That's 1%. What do we know from low burden settings? We know much, 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 much less. This is an old study from Czechoslovakia, where at the time the prevalence of TB was about, or the incidence was about 70 per 100,000, so higher than the United States, but what would qualify as moderate amount in the current era. And at that time, 73% of people who were diagnosed using chest x-rays to trigger sputum collection, 73% of people had no symptoms. And amongst those without symptoms, 21% were smear positive. This more recent study from Alberta, Canada, and so people were evaluated for TB either just based on immigration status or because they had extrapulmonary TB, or they were found, in a workplace screening to have a sort of evidence of TB infection. Out of all people diagnosed in Alberta during this 15-year period, 21% were asymptomatic. And these people were more likely to be younger and foreign-born, have relapse, have smear-negative disease, and also to be HIV negative. All right, so in part, the importance of subclinical TB depends on its natural history. So if most people with subclinical TB self-healed, that does happen, self-resolved, then you would not need to be so aggressive about trying to find it. Now, if everyone with subclinical TB inevitably went on to become symptomatic and smear positive and highly infectious, well, it would pay more to really go out and identify those people early. We don't know the natural history. Looking at old studies, a number of groups have looked at old studies to try and analyze the data. And as you could imagine, you could have an inevitable progression. Someone develops TB and they quickly go, these blue lines quickly go on to clinical TB, or maybe it slowly happens and then they just stay in this equilibrium state where there's a low level and they aren't really that infectious. Maybe people become infectious, but then go on to self-heal. And we've all seen chest x-rays, particularly from non-US born people who look like they had TB before and they deny it. They've never been treated. You may have someone who goes and heals and sort of never develops TB again, or maybe they undulate. Maybe they go periods where they're infectious and not infectious, or with symptoms and without symptoms. If you look at historical data, if you had subclinical TB, about 40% of those people are estimated to self-heal. As opposed to those with clinical, 20% would go on to self-heal. Again, the symptom difference probably reflects bacillary burden, and those with subclinical TB in the absence of treatment would be less likely to die than those with clinical TB. Again, this is just based on review of just various qualities of studies using old techniques, so take it with a grain of salt. Here's another way of looking at it. If you have and are infected with TB, this minimal disease is sort of not microbiological evidence. But you can see there's different patterns. The minority of people who are not treated would go on to die. Many people, even from this clinical state, might go on to recover. Clearly, we're not going to have a new study where we're going to look at what happens to people with clinical TB, whether they recover or not. But this is just to give you a flavor of TB is far more complicated than we appreciate at times, or we've forgotten it already, because this was all known in the pre-chemotherapeutic era. Okay, so does subclinical TB contribute to TB transmission? As I mentioned, the World Health Organization's Eliminate TB strategy long relied upon identifying people with smear-positive disease, because it was thought those were the only people that were infectious, and we know that's clearly not the case. You know, genotyping studies have shown that smear-negative people, even people with extrapulmonary TB, can be responsible for TB transmission. Overall, people with subclinical TB do have, on average, a lower bacillary burden. They're more likely to be smear negative. They're more likely to have an expert high CT value. However, given how common subclinical TB is, 50% of prevalent TB, delays in its diagnosis, someone might have it for 3 or 4 years and be out in the community. They may feel better, so they're able to go out to their job and hop on a bus. It may still make subclinical TB a major driver of TB transmission. Modeling studies, all modeling studies are wrong. Some are just less wrong than others, but modeling studies estimate that 2/3 of TB transmission in a high burden setting, this is high burden, not the United States, is due to persons with subclinical TB. If you look at people with asymptomatic TB, almost 1/3 of those without a persistent cough and almost 1/4 of those without any cough do have smear-positive disease. Indirect evidence about the contribution of subclinical TB, big trials in Africa and Vietnam that looked at community screening found that when you screen based on symptoms, you did not impact TB prevalence in the community. But when you screened everyone, collected sputum from everyone, regardless of whether they had symptoms or not, you drove down TB prevalence. The study from Spain suggests that 1/3 of index people with TB likely transmitted TB before symptom onset. And they were largely sputum negative at diagnosis. So this may be an example of a study that could apply to a setting like the US. And then in Vietnam, when they looked at children who were household contacts, their skin test status in terms of positivity was similar regardless as to whether or not the adult with TB in the household reported symptoms or not. So it is infectious. It can be, I should say. On the whole, it's less infectious than people with symptomatic TB. But the absence of symptoms did not allow you to sort of say they have not transmitted TB. This is just briefly, this is a study from a group in Leicester, England. And when I said that is cough essential for TB, they take face masks, just N95 masks, and put them on people with TB for 30 to 60 minutes. They have little strips in them. They take the strips out, dissolve them, and then put that in either a Gene Expert or some other PCR test. The green lines are whether or not they detected TB DNA from these strips. The blue line is the cough frequency, and the red dots are their sputum bacillary burden. So what they saw is that most people, that basically whether or not you had a cough did not necessarily correlate to your sputum bacillary burden, nor to whether or not you exhaled TB just from normal tidal breathing. So most people, 60% of people, had this highly variable production of TB from breathing over a 24-hour period. Some people did not breathe any out. Some people breathed a low amount out. And some people just breathed out a constant amount. And they found that in one setting, if you breathed out a lot of TB, regardless of your cough, that your household contacts were more likely to be quantiferon converters. There's another even scarier study from South Africa that suggests that you can detect viable TB just from breathing. And so it needs a lot more research to say, to fly in the face of our years of dogma and actually literature showing that bacillary burden is associated with infectiousness. But I think they're going to see a lot more data coming out around this. Near the end, so can we detect people with subclinical TB? So active case finding, can we go out into the community? This is just from a WHO document that shows that, for all people with TB, subclinical and clinical, prolonged cough, greater than 2 weeks, 40% sensitivity. Any TB symptoms, 70% sensitivity. Chest x-ray, and this is probably an overestimate, maybe 94% sensitivity. And so WHO currently recommends for TB screening in high burden settings, chest x-ray plus minus computer assisted diagnosis, rapid molecular tests, symptom screening, or CRP, although CRP performs poorly in some settings. What about mass TB screening? Well, it was done in sort of Europe, Asia, and North America up through the 1960s. And it drove down community rates of TB significantly. In fact, in New York City in the 1930s, chest x-rays on 150,000 people. In the 40s, the US Public Health Service surveyed over 6 million people with mass radiography. And in 1953, 10% of the American population, 16 million people, were screened with chest x-rays for TB. And can I point to this as the only thing that drove down TB rates in the United States? No, but it may have had a role. But in the 1970s, for a variety of reasons, the WHO recommended against mass chest x-ray screenings. Now we do have tools like computer-assisted diagnosis, CAD. This is from one of the Delft system, that you get a digital chest x-ray, so it doesn't even create a printout. And then the software can identify areas of concern and hotspots and give you out a score from 0 to 100. But chest x-ray is not perfect. In fact, a study on which Masa was the senior author from 2008 by Tanilat Paraman showed that 8% of people who had extrapulmonary TB and a normal chest x-ray still had culture positive sputum. So chest x-ray will miss people with pulmonary TB. Now, I mentioned something about signs. So this is from one of our studies. Remember, symptom is what the patient report and sign is what you observe. So we recorded people for 2 hours who were diagnosed with TB in a quiet area on a cell phone, a Pixel cell phone. And if you have a Pixel 8 cell phone, look at it tonight because it's recording you snoring and it will show a record of it. And we found that among 17 persons who denied cough to 2 different interviewers, 70% coughed frequently on mobile phone monitoring. In fact, a median of 20 coughs per hour. One person who denied coughs had 116 coughs per hour. So when I turned over this information to the smart computer science folks, they were able to develop a cough model that can detect TB versus non-TB cough with an area under the receiver operating characteristic curve of about 0.83. So stay tuned for the future, but there's a lot of interest in cough and other biometrics that can be collected by things like your Fitbit, surface temperature, heart rate variation that may contribute to TB diagnosis. So in conclusion, there's many knowledge gaps with subclinical TB. What I presented is largely applicable to a high burden setting. So I am not advocating that you change your current practices at this point, but in a high burden setting, it is likely a driver of TB transmission and the continued high burden. And without identifying it, we're not going to drive down the burden. We lack, though, effective and cost-effective strategies to find and treat subclinical TB, although things like personal devices like cell phones or wearable devices may in the future offer an option for diagnosis. And then I did not up data on this, but people with subclinical TB, it's like when you have TB infection. If you feel fine, you're less likely to take a drug regimen that makes you feel crappy. So people with subclinical TB are less likely to complete their TB treatment. That's just something to keep in mind. Here's some references, and that's the end of the talk.